Morning.
Morning.
Right. I think we're going to wait just a few until we have slightly larger quorum and we'll get going. Everybody have a nice New Year's.
Yep.
Thank you. How about you?
Not too bad. It's a difficult weekend because of terrible loss we all suffered, Dr. Ofori. But it's a new year, and in his honor, we'll do great and learn a lot and take care of a lot of patients, which is what he would have wanted, I'm sure. We'll just wait another second or two, and we'll get going. Welcome, Ms. Kraft, visiting medical
Morning.
student. Hello. I see Sergey just showed up. Hello, Sergey. I guess we're pretty good. Perna's not going to be able to make it this morning, so we'll get going. Okay. All right. This is a tracing that was sent to me very nicely from a colleague and friend of mine in Cambodia, Dr. Savli. So Dr. Savli, who watches these videos, thank you very much for providing these tracings. This is a patient he saw in the past, an 8-year-old with a history of palpitations every 3 to 4 months since he was 5 years of age. So why don't we have Tarek? What do you think we're looking at here?
Yeah, morning, Dr. Pass. So
This is obviously the patient's resting electrocardiogram.
yeah.
Any thoughts on why this patient may be having intermittent palpitations?
So I'm looking at the rhythm first, and I see positive P waves in 1, 2, and AVF. So just sinus.
Yep, agree.
And I think the T wave is inverted in AVL, I believe.
Yeah. What do you make of the PR interval?
So the PR interval doesn't look more than I think 5. I don't see it more than 5 small boxes, so it's not prolonged. But
I agree with you. It's not prolonged. Is it a normal interval though? So it can either be too long or too short. I agree with you. It's not too long. What do you make of the isoelectric period between the P wave and the QRS? Or perhaps better question, is there an isoelectric period between the P wave and the QRS? Because I don't obviously see one. So what do you think the diagnosis might be? What is this little appearance that reminds one of the mustache of the great artist Salvador Dali?
So short PR, less than 120 milliseconds then. So maybe WPW.
Yes, exactly. So if you look here in V4, The PR also is very short with the delta wave. And in the rhythm strip lead 2, I think it's very clear that you have pre-excitation. So presumably a patient who is complaining of palpitations, who has ventricular pre-excitation or WPW, we would surmise that the palpitations may be due to the presence of WPW. But in a child of this age, we would not necessarily believe that until we had documentation. But actually, we see here, Dr. Savli was kind enough to send me a tracing of the patient in tachycardia. So I'm going to now turn the question over to Dr. Bebbia, sorry, Sergey, to ask you, what do you think the mechanism is of this tachycardia?
Good morning, Dr. Pass.
Good morning.
I will be looking at V1 and 3 leads to try and locate.
Unfortunately, Dr. Savli gave us a really crappy lead 3.
Yeah, so V1 would work.
Not his fault. I'm sure it's some kind of artifact, but
yeah. Well, I
will do a favor for you.
Mm-hmm.
That I
okay.
will.
Yeah. So we can see the retrograde P wave, and we can see that the R to P interval is less than 2 boxes. So I would assume it's AV and RT, because that would be less than 70 milliseconds.
Well, that's a good point you're raising. I would agree that if it were less than 70 milliseconds, generally we would think it's AV and RT. But what is this patient's diagnosis that we just saw on the prior screen?
WPW, sorry, of course. He has an accessory pathway.
So it would be a little bit unusual, not impossible, and we always have to keep an open mind. Just because you have WPW does not mean you cannot have it. I'll give you a general rule of thumb. Unfortunately, the tracing quality is poor. You can't really make out the boxes in this blown up image, so I apologize. But as a general rule, and you can't hold your hat on it, but if you can see the retrograde P wave, chances are the RP interval is greater than 70 milliseconds. Okay. And I think you would agree that we do see the retrograde P wave superimposed on the T wave. And again, I'll just show you the sinus tracing. You see there is no such inflection on the T wave when the patient is in sinus rhythm. So this is clearly a difference. Also, I think it's nicely seen in this particular case in lead V3 here. And I actually do think that if you go from the start, the onset of the QRS to the onset of the retrograde P wave, it is probably at least 80 milliseconds. So probably just about 2 boxes. Okay, so then just for the sake of completeness, so the diagnosis would then be what for this tachycardia, Sergey?
WPW, AVRT.
AVRT or ORT, standing for orthodromic reentrant tachycardia. Yes, I agree with that statement. So you're in the emergency room. How would you manage this, Sergey?
So they're in the emergency room.
Yes, you're in the emergency room, and you are asked, you're the big American doctor, and they want to know, how do you want to stop it? You're visiting Cambodia with your family on vacation, and you happen to stop off in the ER, and they say, wait, you look like a cardiologist. Can you help us with this? So what would you recommend?
And is the patient hemodynamically stable or not?
The patient looks okay. He's crying a lot, but basically is okay.
Okay.
Hard to get a blood pressure, but that's probably because the heart rate is close to 200.
I mean, I can try different antiarrhythmics then.
Okay, so you're in tachycardia. How are you getting out of tachycardia?
So if he has WPW and he's pretty excited, he has an accessory pathway.
I mean, don't overthink this. How do we stop SVT?
Oh, then with adenosine, but
Right.
that
You could give the patient adenosine. And what dose would you give, Sir K?
0.1 per kilo.
Okay, so you give 0.1 per kilo and it fails. You don't have termination. What would you do then?
0.2 per kilo.
Okay, so 0.2 per kilo would almost certainly work to break tachycardia. Let's say it did not break tachycardia, or it broke and you went right back into tachycardia. What would your next option or thought be about what you could do? There are multiple things you could do.
Well, then I think I would probably load patient with an antiarrhythmic before I try to break it next time.
I think that's a
So
good.
let's say amiodarone would be one of my choices.
Okay, so you could give amiodarone, and if you were going to give amiodarone, what would the dose be that you would give to the patient?
5 milligrams per kilogram.
That's right. And how long would you give that over typically?
I would give it over, let's say 1 hour, maybe.
That would be my preference. If you look though in PALS, it'll say that it should be given faster, like over 20 minutes. And there is, we worry about, you've heard me say this many times, that I'm always worried about cardiovascular collapse from intravenous amiodarone. That is far more common in small infants. So in an 8-year-old, the chances are not very high that that would happen. In other words, giving it faster probably is safe in a bigger child like this, but I would agree. I don't, ORT is generally in a person with a structurally normal heart, not so hemodynamically embarrassing that you can't wait an hour. And so you would give the amiodarone over an hour. That's probably what I would do. Although just for completeness sake, some would give smaller doses. There are cardiologists who will give a little 1 per kilo aliquots until they have effect. And for example, Tony Rossi at Nicholas Children's Hospital, when treating a lot of arrhythmias, tells me that he often finds that maybe 2 doses of 1 per kilo is adequate. But standard would be to give 5 per kilo. Okay, so you've given it, and then you can give adenosine. Let's say that it happens that in Cambodia, amiodarone is quite easily available, but let's say for some reason there was a problem with distribution that week. You do not have any amiodarone, you're still in tachycardia. What would you do if that were the case?
How about percanamide?
Right, you could give procanamide. And how much would you give of that?
I believe it's also 5 milligrams per kilogram, if I'm not mistaken.
Well, if you read in the books, most books will say that the starting bolus is 10 to 15 milligrams per kilo. But we have moved to giving 5 per kilo as aliquots. And the reason for that is that what is the biggest side effect of procanamide acutely when you're administering it? What do we worry about?
Is it also hypertension and cardiovascular collapse?
So it is hypotension. It's not cardiovascular collapse. You don't see that. Remember that the cardiovascular collapse that we see with amiodarone is really an idiosyncratic reaction to the diluent that it comes in. There's a sugar base called tween 80, which is an alcohol that is what amiodarone comes in. And it is believed that this is an idiosyncratic reaction to exposure to that agent. Procanamide does not have that. Procanamide, though, can cause vasodilation and hypotension on that basis. But what I have learned and seen, and actually it was for my podcast, I spoke with Lizzie DeWitt about 2 years ago, and she explained that at Boston Children's, rather than give the traditional 10 or 15 or even 20 per kilo as one bolus, they routinely give 5 per kilo boluses over about 10 to 20 minutes. And they have found that that has not been associated with significant hypotension due to vasodilation. And that has been our experience now too. So I think doing it that way has made use of that agent a lot safer. So yes, I agree with you. We would give 5 per kilo. We would probably give it maybe over a half hour. But if that were to fail, we would then give another 5 and then perhaps another 5. So that would be another option. Any other options that you could think of medically?
I don't know, Sodalo.
Yeah, you could use IV Sotalol. IV Sotalol is available in some locations. And I don't remember off the top of my head what that dose is, but it is in some centers considered a very effective and excellent first-line therapy. We don't have as much experience here at Sinai with it, but it is certainly a reasonable option. So let me go through with you. Okay, now this is another resting ECG of the same exact patient. So I'm now going to go to Dr. Barris and ask you, David. So this patient, a couple of hours later, this patient actually was able to be terminated with IV adenosine alone and went into sinus rhythm. So I'll just remind you, this is the original electrocardiogram, and patient was in tachycardia, received adenosine, and then about an hour or two later, this is the surface electrocardiogram. So can you make any observations about this or have any thoughts about this WPW in this patient?
Well, it looks like we're not pre-excited anymore. So we have intermittent pre-excitation. So I think that makes it a lower risk form of WPW.
And maybe you can explain what you mean by a lower risk form of WPW, which I agree with everything you've said, but let's be clear.
So in terms of the greatest risk in WPW is risk for sudden death because of rapidly conducted AFib. And there's a lot of discussion as to whether to do EP studies on every patient with WPW in order to do risk stratification to see how quickly their accessory pathway can conduct. And I think one of the factors that might make someone a lower risk and whether or not you would automatically do an EP study is whether they have intermittent pre-excitation or not.
Right. So in general, we would think that the presence of intermittent pre-excitation would be a good indirect sign that the pathway may be not as robust, cannot conduct at fast rates. That is probably true on average. There are, of course, cases in the literature of people who have intermittent pre-excitation who still on formal testing are not low risk. So unfortunately, we cannot hang our hat on this observation, but it is certainly a encouraging one. And I personally think that if I had a patient who had WPW who was not having tachycardia, if I saw intermittent pre-excitation, I might be inclined to do nothing more until or if the patient had SVT. So let's go through some of the questions that Dr. Savli had for me. It says, in sinus rhythm, no delta wave and normal PR, but when she falls asleep, I see delta wave, short PR, and a wide QRS. And he surmised that that was from increased vagal tone, which is a good explanation. He's suggesting that the AV node is not conducting as well asleep, and therefore it's encouraging accessory pathway conduction. And he wrote, this can predict low risk. He's asking, can it predict low risk WPW? Again, exactly what you just said in regards to risk for rapidly conducted atrial fibrillation. And then he asked, can I guess that the bypass tract is at the right posteroceptal region? So this is the baseline electrocardiogram. And so typically I'll pull out my little Oklahoma map from the group at University of Oklahoma. And again, we go through step one. In lead one is, and this is again, all of these questions are referring to the axis of the delta wave. So in lead one, is it isoelectric or negative, or is V1, is the R wave greater than the S wave? And in either case, that would put it to the left side of the heart. So in lead one, we do not have an isoelectric delta wave. The delta wave is actually positive. And in lead V1, I think we would agree that the S wave is far greater than the R wave. There's essentially almost no R wave at all. So I'm sorry. So that is clearly not true. So we move then on to step two. Is the delta wave negative in lead two? And in lead two, I think we would agree, which direction is the delta wave, Dave?
Looks like it's positive.
Yeah, it's positive. So that fails. I'm sorry, that fails that question. So now we're going on to step 3. Is the delta wave isoelectric or negative in V1? So here we are in V1, and I think actually we would agree that the delta wave is negative. It's downward in V1. So I'm going to give that a yes. So that would suggest the pathway is septal with a sensitivity of 97% and a positive predictive value of 94%. So fairly good that we're going to be somewhere on the septum. And then it asks the question of what is the axis or the polarity of the delta wave in AVF. And if we look in AVF, this is a little challenging because first of all, the patient isn't very pre-excited, but I think I would say it's probably positive, but it's very hard to tell. It could be isoelectric. So this is where this can sometimes be a little difficult. So either positive or isoelectric. Oops, wrong tracing, sorry. And then they ask if the QRS axis is greater than or equal to 0. I think we agree it's upright in 1 and F, so it's greater than 0. So I think it's probably, well, let's look again at this AVF. This is really the whole ball of wax. I think it could be, I think I would say this is probably isoelectric, honestly. And if it's isoelectric, it would put it in the left posterior septal region. So it's hard to say though, because the patient is not very pre-excited. So this type of schemata here is helpful when the patient is very pre-excited. When they're not very pre-excited, it's a lot harder and it's not quite as accurate. And of course, remember that this was developed for adults, not for children. So let's go back to the questions that Dr. Savley had for us. Should I give flecainide? And when would we consider ablation? The first question, should I give flecainide? Certainly, flecainide would be a reasonable agent to give to a patient with WPW. What would be the advantages of flecainide, do you think, David, for a patient with WPW?
Slow pathway conduction.
Yeah, flecainide actually has direct effects on accessory pathway conduction. So it's conceivable that the administration of flecainide may affect the pathway directly. And what would be the benefit of that if it did have a direct effect on the pathway?
I guess your highest rate that you would be able to conduct down the pathway would be slower.
That's true. And of course, it would reduce the chances of tachycardia, SVT, right? Or ORT by slowing pathway. What could be the potential danger of using flecainide, do you think?
You could have, I guess, flecainide toxicity. Also, it's one of those medicines that needs to be often it's compounded and needs to be shaken before you administer it. So
that's true. So flecainide has a very narrow therapeutic index. So it's a great medicine, but if it's dosed too low, it's not going to work. And if it's dosed too high, it could have some serious side effects. And the difference between enough and too much is very small. And so patients can sometimes have trouble with flecainide. So flecainide is not a bad idea for sure, but probably would not be my first choice for somebody with WPW. So then the last question that we'll address from Dr. Savley is, when would we consider ablation for a patient like this? So what do you think about this? So let's say, just for the sake of this conversation, that based upon the map, let's just say for the sake of discussion that we think it's septal and it's either left or right posterior septal. What do you think about doing an ablation in an 8-year-old like this? What are the pluses and what would be the negatives?
I think the positives would be if the 8-year-old was having frequent tachycardia and they were symptomatic, you'd be able to give them symptomatic relief.
Yep.
I guess the benefit of lowering the risk for sudden death is not as good in this patient because we said it was probably a lower risk pathway.
Right. Right. Although again, there are people who it's possible it's not low risk, but yes, you're right. That would be less of a compelling reason to ablate for sure.
I think
What
if
would
you're
be the-
posterior septal, you probably have risk for a coronary injury.
That's exactly right.
So that's why it would be kind of a risky endeavor if you were to do it.
Right. So, there are a lot of cardiologists who would just say, well, I'm going to do it anyway. But that would be my biggest concern is that the posterior septal region is, you remember that the thickness of the myocardium at that location is not very great. It's actually one of the thinnest areas in the heart, and the distance from endocardium to epicardium is the smallest in that area, particularly in the right posterior septal region. And so in smallish children, one would have to be at least very cautious when using RF in that area. So one option would be to take the patient there and potentially either use very small aliquots of RF energy or perhaps even safer to consider doing cryoablation there, because cryo has very rarely, if ever, been described to cause coronary occlusion. There are some reports rarely in the literature, but generally speaking, cryo is considered to be much safer vis-a-vis ablation of accessory pathways and injury to coronary arteries. And what would be the disadvantage of cryo, do you think, Dave?
More likely for the pathway not to be successfully ablated.
That's right. You can have recurrence risks much higher with cryo. Just the other day, in fact, we saw a patient that I ablated in the mid-septum. I think it was 12 years ago, successfully. And I even saw the patient 5 years later, and they were not pre-excited. And now, 11 or 12 years later, they are pre-excited with the same pattern as they had when I first met them, when I used cryo. The patient at that time, though, was very young and small, so that's why we used cryo. But that's very unusual, but it is a little disappointing to see that somebody so many years after a cryoablation had a recurrence. So something to think about. Okay, let's move on. Good job. All right. This actually also was a case from Dr. Savli. It's very kind to send me some interesting tracings, also from Cambodia. This is a 45-day-old who has dyspnea and bradycardia, a secundum ASD, and a small PDA. And I just want to see. This is the patient's chest X-ray. It's nice enough to send to me. And so the question is, what do you want to do? Does the patient need a pacemaker? Should the ASD be repaired? What about the PDA? Patient has a small degree of dyspnea and bradycardia. And so let me ask Dr. Duong, who's visiting us from the non-invasive imaging world. So what do you think, Sonny? You have a 45-day-old who comes in with dyspnea, is bradycardic. First of all, what do you think the rhythm is? Let me show you the tracing a little clearer. So maybe you can comment on what the rhythm is and what you think.
Okay. Happy New Year, Dr. Pass.
New Year.
So the rate's quite slow. 100. Something like, oh gosh, it's like so slow. I gotta count it's in the 30s or 40s.
I think it's in the 40s, yeah.
Yeah.
Pretty slow even for us, but certainly for a baby.
And then in terms of the rhythm, the I'm looking at every lead just to make sure. I don't think I see a clear relationship between the P's and the QRS. I want to say this is complete heart block.
That would be correct.
And
What is the atrial rate about?
oh, atrial rate is about 150 or so.
Yep. Which would be a much more normal
Yeah,
rate,
normal,
right?
yeah, normal.
For a 45-day-old. So how would you decide about what to do with this patient? So I'll tell you, Dr. Savli said that they were considering the possibility of a pacemaker plus ASD repair and PDA ligation. What are your thoughts on that approach?
Yeah, so the heart rate is like worryingly low. Is the patient like awake or sleeping during this?
Patient is fine, but does have some dyspnea, so is breathing rapidly.
So
so how do we decide?
I think the resting heart rate, in the 30s kind of meets criteria for a pacemaker in a neonate in the 40s. And so I think the patient meets a primary indication for a pacemaker based off of bradycardia and descending complete heart block. And then in terms of why the patient has bradycardia, if this, I'd like to check the patient for presence of maternal SSA and SSAB antibodies as a potential primary reason for the heart block.
An easier way to just check the mother, right? To see if she has lupus. And in fact, lupus is very often diagnosed for the first time in a mother with the presentation of an infant having complete heart block. But yes, I would certainly do that. Would you do, and you know already that the echo apparently showed normal function, but has secundum ASD and the small PDA. So what would you do? So you've decided, let's just first review what the indications are for a pacemaker in the setting of a congenital complete AV block. These are all this is actually a relatively new document that just came out last year. It's the first time in nearly a decade that it was adjusted. So the first three are the class 1 indications. A class 1 indication is one that the AHA thinks is, do not pass go, do not collect $200. You must do this. So pacemaker implantation is indicated for patients with congenital complete block with symptomatic bradycardia. So in this case, the dyspnea, I think, would be a sign of symptoms that we would probably say meets class 1 indication for a placement of a pacemaker. Also, pacemaker implantation with complete congenital heart block and a wide QRS escape rhythm or ventricular dysfunction. We do not have that in this patient. In an asymptomatic neonate or infant, when the mean ventricular rate is less than or equal to 50 beats per minute, and the ventricular rate alone should not be used as an implant criteria, as symptoms due to low cardiac output may occur at faster heart rates. So actually, your initial comment about the fact that the resting heart rate was in the 40s, that in and of itself would not be considered a class 1 indication. If, however, the average heart rate were there, or if the patient was symptomatic, in this particular case, dyspnea, those would be considered indications. But it's not uncommon that you'll see a patient with congenital complete block in the office who might be sitting at 39, but when you actually get the Holter, the average heart rate is 59 or something like that. Okay, a 2A indication is an indication where basically the AHA is saying most people would do it, and we would recommend doing it, but you are not like a bad person or a bad doctor for not doing it, but the majority of people would recommend it, and these indications would be permanent implantation is reasonable for asymptomatic congenital complete heart block beyond the first year of life with a mean rate less than 50, or if there are prolonged pauses in the ventricular rate. This statement is something that we struggle with because we have a handful of patients who have congenital complete block who are hovering around 50. They'll have a Holter 1 year at 47 and the next year at 52. And so we always, in an asymptomatic patient, it's always a difficult question. Another indication, which is a 2A, is congenital complete block with left ventricular dilation with a Z-score greater than or equal to 3, which is also associated with significant mitral insufficiency or systolic dysfunction. So just having a dilated LV is actually a normal response to heart block. But if it is so dilated that it is causing a failure of coaptation of the mitral leaflets or dysfunction of the heart, that would be considered a 2A indication. And that's actually a relatively new indication. And then a 2B indication is one where it basically what the AHA is saying is, some people do this. We would not actually generally recommend this, but it is not malpractice or bad to do it necessarily, but we would not necessarily think it's a good idea. And so that would be permanent pacemaker implantation and congenital heart block in an asymptomatic adolescent with an unacceptable ventricular rate and narrow QRS and normal ventricular function based on individualized consideration of risk-benefit ratio. So that's the question. So somebody is asking Dr. Ekomu whether or not a long pause, how long of a pause is long enough. I think in general, if you read the document, it says something like, if there's a sudden pause that I think is greater than double the surrounding rate, that would be considered a prolonged pause on a Holter. So in actuality, I would say this patient probably does warrant a pacemaker based on the symptoms. I would certainly do a Holter because there would really be very little downside to that. And it might even offer another indication. The question then is whether we should address the congenital heart disease. Generally speaking, as you know, we do not close ASDs in 45-day-olds, nor do we normally close small PDAs in patients this size. Now, if it happened that during the surgery for pacemaker implantation, you could reach up and get the PDA, certainly there would be no harm or minimal risk to doing that. I wouldn't be opposed to it, but most of the time these operations are done from the front, and probably reaching back to the PDA would add a little bit of difficulty and risk for something that's probably minimally necessary. And would you put in, Sonny, a single or a dual chamber pacemaker in this this baby, you think? Doesn't matter.
Well, so if I could, I think I'd prefer a dual chamber pacemaker because I need to kind of sense the A and have kind of AV synchrony would be kind of optimal. I mean,
Yes.
this patient has congenital complete heart block lifelong, and his lifelong ventricular pace is at risk for pacemaker-induced cardiomyopathy. And so, yes, I would like to do that.
So yeah, a dual chamber pacemaker would be probably optimal. I will be honest with you in saying my personal recommendation would probably be a single chamber device, a VVI device. There is actually no evidence that dual chamber pacing reduces the likelihood of development of pacemaker-induced cardiomyopathy. It's actually just the pacing of the ventricle that does. There are data, though, that suggests that pacing either the septum or more likely the left ventricle is associated with a lower risk for cardiomyopathy from pacing. And so I would probably ask the surgeon, if possible, to try and put the lead on the LV. And actually Raghav, who does a lot of our surgeries, Raghav Murthy, he often tries very hard to put the lead on the left ventricle because of his understanding of that literature, which is good. And I normally recommend that only because it's just less hardware in the patient. And there are, as you know, some recent reports demonstrating the strangulation of coronary arteries from epicardial pacemakers that are lying on top of the surface of the heart. Typically, it's the back of the lead, not the part that's actually touching the heart, but the other part that over time with growth is somehow causing compression of coronaries. And it's a very, very bad problem when it happens, and probably is underappreciated. The group in Boston has reported this, and now there are more reports of it. So my personal bias is less is more. The impact of dual chamber pacing in terms of cardiac output in an otherwise healthy infant is probably only going to be a 5 to 10% increase in cardiac output. As opposed to, say, a sick post-op patient or a sick congenital patient in which AV synchrony can have a very meaningful impact on cardiac output. But I would say that if you have a patient who's otherwise well, has essentially very mild congenital heart disease with a secundum ASD, PDA that may even close on its own, my general bias would be probably to put in a single chamber, but I would certainly never say a dual chamber is wrong. And many, many centers would put a dual chamber system in. It's certainly not a bad idea, very reasonable, probably the optimal approach in terms of cardiac output, but just thinking in the totality of the patient and amount of hardware in the body, et cetera, I probably would go with simple, but there is certainly nothing at all wrong with having a dual chamber device. And I'm sure you've all seen that in our complex congenitals who have heart block, we almost always put in dual chamber devices. Although in ancient times, 20, 30 years ago, single chamber devices were routinely placed in those patients, and shockingly, they all did very well as well. So. And so I think with that, we're going to stop for today. Happy New Year to everybody. We're going to have a wonderful, great year. I was thinking maybe we can resurrect my rounds on Wednesday. So if you are available on Wednesday at 7:15, we're going to do a hemodynamic case. So if you're interested, feel free to join. I'll put out an email to that. Have a wonderful day and a happy and healthy New Year to everybody.
Thank you, Dr. Pass. Happy
Thank
New
you.
Year.
Thank
Great day. You're well.